Assalamu alaikum. Good morning. My name is Dr. Salman, and my moderator is Dr. Faisal Hanif. And today's the topic of my presentation is fundamental of surgery on children. So the learning objective is pre, per, and post operative care and pediatric age group. So this is a question from both all the children, little adult.
So, Adil, do you think that the children are little adults on the basis of anatomy, physiology, pathology, and pharmacology? If yes, then why? If no, then why?
Yes, they are.
So, how?
Not exactly. I don't know exact answer.
Anybody else? आप बताएं भाई. डॉक्टर उस्मा कह रही है कि जो बच्चे हैं दे आर लिटिल एडल्ट्स ऑन द बेसिस ऑफ एनाटॉमी फिजियो पैथोलॉजी एंड एज वेल एज फार्माकोलॉजिकली. माइक दीजिएगा.
Yes, sir. Because they all have the same anatomy and same pharmacology for the drugs, but they have a little difference. That is dose difference. And
Those
according to the medicine, we prescribe
those
it.
differences.
Yes.
So what book as well as Dr. Salman thinks we will know in the next slides. No?
Thank you.
So these are the answers. They are different in anatomy, physiology, pathology, pharmacology from the adult. One must understand this difference and appreciate them to properly assess, plan, and deliver surgical care. So the body surface in peds are more per weight. Head is large compared to adult in exceed. Urinary bladder is intraperitoneum. Bone growth occur at different rate throughout the body, which affect anatomical landmark.
So
Second,
Salman, take on. The head circumference is a bit more than the rest of the body, like we see in adults. So there is more heat loss if we anticipate any surgical exposure to such patient, as well as we know that the bone growth occurs at different rate in pediatric age group. So if during a surgery, not in urology, but in orthopedic surgery, if we damage the epiphyseal plate, so the growth of that bone will be affected. And there will be stunted growth or disparity between the growth of two limbs. As well as the bladder is intra-abdominal in pediatric age group, while in adult population it is intra pelvic organ. So the anatomical landmarks are different. Though they have the same organ, but the anatomical landmark for the surgery are different in pediatric age group. So we have to understand these landmark before operating on the patient. As well as they have different physiology, we will discuss in next slides.
so sacrum is not normally fused at birth, and spinal column is only anterior curvature. So higher mental function are underdeveloped, and the neuronal development complete till at 12 year of age. Myelination complete at the age of 2 to 3 years. Spinal cord terminate at the level of L3 in neonate. Stroke volume is fixed in infant. Cardiac reserve are limited. Obligate nose breather only have mouth breather well crying. Respiration is mainly by movement of diaphragm.
So in this slide, what does it means? How does it signify that if the stroke volume is fixed, does it cause any change in patient blood pressure or cardiac output? Anybody? As we know, the cardiac output is dependent on heart rate as well as the stroke volume. So if the stroke volume is fixed, if the infant cannot increase the stroke volume. So the heart rate, so the blood pressure is solely dependent on the heart rate. So in neonates, you have seen it that their pulse is more than 100. So it comes down to the adult level at the age of 5 years. So in a newborn, the heart rate of 140 to 160 is usually considered normal because they increase their heart rate in case of dehydration. They cannot increase the stroke volume or preload. They increases the heart rate, but up to a certain limit. So if you will not resuscitate the kid properly and there is ongoing blood loss or fluid loss, they increase the heart rate to compensate the blood loss to maintain the normal blood pressure. So up to a certain limit. But if you will not compensate that blood loss or fluid loss, so it after certain level, because of low cardiac reserves, the patient may suffer any acute event or death.
So smaller diameter of airways are more to block. New alveoli are developed up to 8 years of age. Even high oxygen can cause retrolental fibrosis. GFR in neonate is 30% of the adult. Neonate are immunocompromised as they don't have antigenic exposure and have depletion complement factor. So low level of pharmacology now. Low level of plasma albumin and high level of free drugs. Drug excreted by kidney like pancuronium, digoxin can be markedly affected by immature renal function.
So you are right that in neonates and pediatric age group, there should be dose adjustment, but not only the dose adjustment because the albumin level is low. So the more free drug is available to act on the receptors, and there can be more complication if we do not titrate the dose accordingly. As well as the kidneys are immature, we have learned that in the neonates there is a 30% of the GFR of date of adult. So the drug excretion is also affected. So we have to look into these things too before prescribing any antibiotic or any inhalation or IV drug to the patient.
So the perioperative care are divided into 4 groups: preoperative, intraoperative, postoperative, and post-discharge. The basic aim is to provide early recovery after surgery via early mobilization after surgery, use of analgesia, early removal of drain, encourage orally, advancement of diet, and decrease length of hospital stay. So, preoperative preparation include anesthesia risk assessment, preoperative setting, special consideration, NPO status, diabetes and metabolic disorder, medication administration, and preoperative studies. So, in anesthesia respect, administration of anesthesia is not without any risk, and certain conditions such as upper respiratory tract infection, asthma exacerbation, dehydration, uncontrolled diabetes, premature and febrile illness increase the risk for complication. Rarely but more severe risks include allergic reaction to anesthetic drug, anaphylaxis, aspiration, malignant hypothermia, and death can occur. Preoperative setting is the foundation to ensuring a safe procedure, favorable outcome, and satisfied families. Preoperative distress and anxiety should be considered in children. It is the predictive of post-operative pain level and behavior. In special consideration, children in the custody of Department of Social Service may undergo surgery with the consent from court order, legal guardian, and designee. Patients with metabolic disorders such as glycogen storage disease, urea cycle disorder cannot tolerate period without glucose. So must have to be given glucose fluid well in status of NPO. So it should be the goal that all diabetic patients should be the first case to start. Weight and glucose level should be checked before the induction of anesthesia. Only those patients are selected for elective surgery whose glycemic control is optimized. So metformin stop before 24 hours before procedure because of long half-life and the risk of lactic acidosis. While other oral hypoglycemic drugs should be discontinued 1 day before surgery. Insulin-dependent patients should receive their dosage on the day before surgery. So these are NPO status. So far, clear fluid 2 hour for breast milk 4 hour. Infant formula, non-human milk and light meal should be 6 hour. And for regular meal should be 8 hourly. Preoperative enzyme NPO status instruction, but that should receive carbohydrate clear fluid and avoid drug that can increase gluconeogenesis such as dexamethasone. Anterior tube padding should be continued 6 hours before the induction of anesthesia. However, Pedialyte can be given up to 2 hours before induction. In post-pyloric tube padding, they can be continued due to the less chance of gastroesophageal reflux and pneumonia. So certain medications should be continued and certain should be stopped. Anti-seizure, gastroesophageal reflux, and asthma medications should be continued. And certain drugs like aspirin 7 days before procedure and say 24 hours before procedure, or hypoglycemic 1 day before procedure, warfarin 4 days and heparin 4 to 6 hours before procedure should be stopped. Prophylactic antibiotics should be given at least 60 minutes before procedure, according to recommended guideline or local hospital protocol. Broad spectrum antibiotics should be prepared. Tetracycline is contraindicated in pediatric age group. Cephalosporin is contraindicated in neonate because it causes hepatic dysfunction. So the baseline laboratory investigation should be done pre-procedure include pre-procedure indication in ACA recommendation such as ECG, labs, chest X-ray, pulmonary function test, urinary. Some comorbidity like in premature infant, those born before 37 week of gestation, and micro preemie before the 26 week of gestation. In immature organ system, inadequate surfactant level lead to apnea and hypothermia. Premature infant have high risk of post-operative apnea during the first 12 to 23 hours of post-anesthesia, which can result in death. Therefore, post-op 23rd hour monitoring is important. Warm environment is recommended to avoid hypothermia. Those who have asthma and pulmonary disease. So most the dangerous time per airway even as during induction in emergence from anesthesia because of mechanical stimulation and vigilance is required for early recognition and treatment. In upper respiratory infection, the risk for adverse events such as surgery should be delayed for at least 2 to 8 weeks, depending upon the severity of disease. Those who have cardiovascular anomalies, they have higher reported rate of perioperative cardiac arrest with increased risk for perioperative morbidity and mortality. Evaluation of surgical need is necessary. In CKD patient with anemia and preoperative blood transfusion to deal with the adverse effect. And platelet dysfunction increase the risk of intraoperative bleeding. So in CKD stage 3-4, instead should be avoided. It worse the renal function in children. Preoperative hyperkalemia increase the risk for cardiac arrhythmia. In hematological disorder, most common inherited disease such as thalassemia and structural hemoglobin variant. Most common sickle disease. Acute syndrome is the main cause of death during anesthesia and sickle cell disease patient. Preoperative assessment of such patients should be done carefully. Those in oncological patient must undergo elective or emergency procedure at any point because it can cause cardiac toxicity, which lead to arrhythmia, cardiomyopathy, and congestive heart failure. Bleomycin can result in pulmonary toxicity. It can be fatal in severe cases with exposure of high inspired oxygen level lead to anesthesia resulting in pulmonary toxicity. In peuchromocytoma patient, so a fatal complication can occur during induction of anesthesia. For children, medication can be given with the goal of blood pressure reduction of less than 50th percentile per the age and height. And this will be achieved with the given of alpha 2 antagonist before beta 2 block to prevent the likelihood of severe hypertensive crisis from unopposed alpha receptor stimulation. Post-operative hypoglycemia should be monitored because of acute catecholamine reduction and resulting of elevated insulin level. In congenital adrenal hyperplasia patient, so it is autosomal recessive disorder of cortisol biosynthesis. During stress, such as surgery, patients are unable to mount appropriate cortisol response. Such patient require stress dose of steroid given intravenously with IV fluid. Monitor per low glucose level should be checked due to cortisol deficiency. Those patients who have spina bifida have potential of multiple comorbidities which should be considered preoperatively. Patient with VP shunt, adequate shunt function is necessary to avoid intraoperative complication. Patient with high level of neural tube defect between T5 and T8 are increased the risk of autonomic dysreflexia. So in acute perioperative event, these can happen sepsis, trauma, upper respiratory tract infection, UTI, and non-specific fever. So sepsis is leading cause of mortality and morbidity in infants and children. So broad spectrum antibiotics should be started initially to cover all pathogens. In traumatic patient, pediatric trauma victims should always be considered full stomach, and rapid sequence of induction is the gold standard. Life-saving intervention is needed. In upper respiratory tract infection, the risk of operative respiratory adverse event, usually surgery is delayed or proceed with caution. In UTI infection should be eradicated before surgical manipulation with antibiotic. Patients with recurrent UTI are considered high risk for post-operative infection. In non-specific fever, consistent infection and non-infection cause, evaluation should be done through surgery or not. So these are some intraoperative considerations. Pediatric anesthesia mainly with endotracheal control anesthesia. Epidural spinal and cardiac anesthesia can be used with sedation. No locoregional anesthesia is recommended due to difficulty in maintaining airway. So mostly we given in children transverse incision. Laparotomy closure can be done with absorbable suture. Preoperative antibiotics. Surgical site infection are the major cause of increased morbidity and mortality. Re-administration and extended length of hospitalization. Administered to reduce the risk of post-operative infection, preoperative dose of antibiotics should be occur within 60 minutes of surgical incision. Common side effect antibiotic are allergy, reaction, gastrointestinal septum, antibiotic resistant. Due to large body surface of children are more prone to hypothermia, require large energy expenditure to maintain normal core body temperature. So we give warm IV fluid blanket to prevent hypothermia. Anaphylaxis can be occur due to neuromuscular blocking agent and beta-lactam antibiotic and preoperative anaphylaxis. Management include immediate cessation of drug, and then we'll give 100% oxygen, Trendelenburg position, aggressive fluid therapy, albuterol, epinephrine, and surgery should be postponed in these cases. Malignant hyperthermia is a hypermetabolic disorder triggered by succinylcholine, an inhaled anesthetic agent except nitrous oxide. If such event occur, then the procedure should be suspended, and all trigger agents should be stopped. Backup support should be requested. So intraoperative pain management depend on patient factor, surgical factor, and comfort level of anesthesiologist. So epidural anesthesia is good choice for large and single site surgery. Neuraxial and regional anesthesia is safely performed in anesthetized patient. IV lidocaine has been shown to be beneficial. Is a multimodal analgesic approach intraoperatively. IV ketorolac can be safely used in neonate less than 6 months, but is reserved for infants 6 months and older with normal renal function. So in fluid management, fluid turnover is 7 times greater than that of adult. So have more risk of dehydration. Organ perfusion and metabolic count are need adequate hydration. Optimal fluid management to the patient is based on fluid deficient maintenance fluid and intraoperative fluid loss.
So why dehydration is catastrophic for the neonates and pediatric age group? We have discussed earlier. Dr. Farzeen? No. So why dehydration is more prone to cause death in neonatal age group than in
Because their body weight comprises more of the water. And their total surface area is also greater, so they are prone to hypothermia more.
So as we have discussed earlier, that the neonatal age group, their cardiac output is solely dependent on heart rate. They cannot increase the stroke volume. So in case of dehydration, they increases the heart rate to a certain limit, and beyond that, they can cause, and because of low reserves, not cannot as they cannot increase the stroke volume, so it can cause hypotension and death as well if we do not resuscitate the patient adequately.
So fluid class can be from emesis, angiotype, and fistula. So electrolyte and acid base imbalance should be corrected before going to surgical intervention. For premature infant, 150 ml per kg per day is recommended. So these are the Holiday and Cigar rule 4 to 1 per first 10 kg we give 10 ml per kg per hour. Then per next 10 kg 2 ml per hour per kg per hour. And per next kg 1 ml per kg per hour. So the choice of fluid is we can give fluid via intravenous or intraosseous route. So dextrose is metabolized in blood, although 5% dextrose solution is isoosmolar to plasma. Ceylon has greater chloride content than plasma, also than Hartmann and Ringer, and they may cause hyperchloremic acidosis. Balanced salt solutions such as Hartmann or Ringer are slightly hypotonic and may result in fall in serum sodium if given in large quantity. Current guideline recommended full strength dextrosilan for maintenance fluid replacement. However, half strength dextrosilan can be given in pediatric age group.
So, Dr. Zakarullah, why 5% dextrose is hypotonic in the body? Why it is isotonic usually?
Because of the osmolarity of this.
No, 5% is not.
If hyposmolar.
No, it is not hypoosmolar. 0.45% dextrose is hypoosmolar, but 5% is not hypoosmolar. But it is considered hypoosmolar. Why?
0.9%.
Because
5% dextrose, not common plan.
when we infuse dextrose, glucose is used by body, and the remaining free liquid becomes hypotonic.
Yes, free liquid that is water. So it is considered after metabolization. It is considered as hypotonic.
Hypotonic.
So during surgery, use of Hartmann or Ringer or blood is clinically indicated. Low dose of 10% dextrosilan may be required per unit, and those at risk of hypoglycemia check the blood sugar regularly. Administering too much normal saline can cause hyperchloremic metabolic acidosis.
So why 10% dextrose is recommended in neonatal age group? Dr. Aslam? Dr. Ain? Any volunteer from the resident? Dr. Shumaila? Because the liver is not fully developed in neonatal age group. So gluconeogenesis is impaired. So during the surgery, because of the stress, there is high consumption of glucose, but the gluconeogenesis is impaired. So neonatal age group, these patients are more prone to become hypoglycemic. So 10% dextrose is recommended in neonatal age group intraoperatively. It can be given, and we have to monitor the sugar regularly in neonatal age group in preoperative, operative, and postoperative period.
So in post-operative patient, respiratory, even like hypoxia, airway obstruction, laryngospasm, bronchospasm, in post-operative pulmonary edema and aspiration can be occur. So it should be in priority list. Post anesthesia care unit and pain management extremely distressful to patient, care provider, and parent. So post-operative pain plan should be placed on time. Discharge from post-anesthesia care unit can be achieved when patient is returned to their baseline function with normal hemodynamics. So these are lists can be checked before patient shifting from recovery. Respiratory function should be normal. Cardiovascular status should be okay. Mental status should be okay. Temperature, nausea, vomiting, pain, and hydration should be checked before shifting from recovery. Appropriate post-op patient management in the pediatric patient is the major concern because of our challenge with the pain assessment and concern about the opioid side effect. Poor pain management can lead to increased recovery time and increase in mortality and morbidity. A combination of acetaminophen and NSAID is the basis for the treatment. Decrease opioid use by 30 to 40%. Opioid can be used for breakthrough pain with the side effect of nausea, vomiting, pruritus, constipation, and respiratory distress. So in PACE assessment tool, the commonly used pain assessment scale in children are 1 Baker PACE pain rating scale and numeric pain rating scale. Self-assessment to the rate pain is not present in children less than 3 years of age. So in numeric rating scale, we have 10 number, 0 no pain, 5 moderate pain, and 10 worse pain. In 1 Baker pain scale, we assess the severity of pain through the paces of patient. So these are different type of paces which we can get the severity of pain. Route of administration. Sometimes it is difficult to gain cooperation. Liquid arm have greater absorption. Mostly painkiller we give intramuscular over the age of 2 years in gluteus medius muscle use over at the age of 2 years. In vastus lateralis under the age of 2 years. So these are some medication which painkiller which are narcotic and non-narcotic. In non-narcotic, we can give acetaminophen, ketorolac, ibuprofen, naproxen, and silicazib. In narcotic, we can give morphine, hydromorphine, oxycodone, hydrocodone, fentanyl, meperidine, and methadone. So now minimal invasive surgery in children, which include those laparoscopic and robotic surgery. Pediatric urology manage a wide variety of congenital enamel abnormality. The pediatric urologist apply minimal invasive surgery technologies need to be nimble, creative, resourcefulness. They promote method to stimulate and evaluate pediatric surgery in effort to derive improve patient outcome. So these are pros and cons for minimal invasive surgery. The advantage will be cosmetic benefit, convenience, pain control, less physiological stress, and ergonomic. And disadvantage will be cost effective, learning curve, ergonomic, and specific complication like port site hernia, complication of pneumoperitoneum. So the physiological change occur during pneumoperitoneum, which cardiovascular change include tachyarrhythmia, hypercapnia upon the absorption of carbon dioxide, change in cardiac pre and after load. In pulmonary change, which include intraoperative pulmonary function, prolonged effect of carbon dioxide elimination. Intracranial changes like hypercapnia, which can cause cerebral blood flow. In renal changes, oliguria, inuria due to decreased renal blood flow, decreased GFR, release of renal injury marker, and acidosis can be occurred. Stress response to pneumopuretem, which include release of catecholamine, cytokine, epinephrine, and non-epinephrine. Thank you.